Yeah.
Yeah.
It's okay.
This is also not. Can you switch? Yeah. So thanks, Dr. Lalit, Dr. Parthas, and the AIOS team for this honor to deliver the Dr. Gullapalli Endowment lecture on the theme of science of ophthalmology and my philosophy. I'm really honored to give this talk named after Dr. Gullapalli Rao, who created an excellent and equitable eye care model in LV Prasad, covering 4 states and probably covering more than about 120, 130 million population in that area. If you look at the science of ophthalmology, we all know that it's about covering patients, caring for patients who are blind or visually impaired. With the recent advances in the basic sciences, now we are able to diagnose some of the difficult conditions, immunological, genetic conditions. And we also, not only we can diagnose, we also have new drug molecules, newer biologicals, gene therapy to treat them. And we also have newer surgical technologies, which you go out, you'll be able to see it, and you are able to give the best of the care to the patients. And at the same time, it's also about inequity in care delivery. A large number of patients who are disadvantaged socioeconomically. If you take the women, the prevalence of blindness is 36% higher. It's much, 3 to 4 times higher in illiterates and also in unemployed people. And today, the current health system, the way we have designed our system, don't address the access challenges of this underserved population. Even more important, with the development of ophthalmology, the modern ophthalmology also have become complex. For example, if you take cataract surgery, there are at least 3 or 4 surgical options available. There are about 20-25 intraocular lenses available. The power ranges from -10 to +30. All of this makes the whole eye care very error prone. And recently there was an article in the year 2018 looking at the surgical errors which happen in surgery, not just ophthalmology surgery. The period covered for about 7 years, and it's in the Veterans Administrative Hospitals in America. They looked at about 32 lakh procedures done over a period of 7 years. They found there were 277 surgical errors. So it's not just ophthalmology, but all the other specialties as well as because of the protocols, they were able to prevent about 206 other errors. If you look at what are the common errors, they operated on the wrong side, including a wrong lung, a wrong implant in about 86 patients, and a wrong site, wrong vertebra, wrong. The teeth was operated in about 65 cases. And the 277 covers all the specialties. But if you see what comes on the top, 72 out of the 277 were ophthalmic cases. And if you look at what is the average error, it's about 1 per 20,000 across all specialties. But if it comes to ophthalmology, it's 1 in 10,000. Ophthalmology is almost the chances for error is almost double. And the most common root cause for the error is not performing a comprehensive timeout, which could have prevented this in nearly 30% of the cases. This is again reinforced by another paper that was published by Archives Ophthalmology. They comprehensively covered about 900,000 surgical procedures done in the state of New York during a period of 5 years. And they reported there are about 1 incidence, surgical error incident per 15,000 surgeries, which includes a wrong lens implant, wrong eye, wrong block, wrong procedure, the transplant. Here again, a safety protocol could have prevented about 85% of the cases. So as my journey, I've been the chief medical officer of different hospitals for the last 25 years, and as a chairman for the last 10 years, and also as a director. My main aim is how do we deliver quality eye care to the large volume of patients who come, especially those, which also includes a large number coming from rural areas who are illiterate. And of that, I really attach a lot of importance to safety. So let us understand, I give you a few examples how errors happen. So here is a rare scenario where a patient had been advised left eye cataract surgery. The advice was correct. Whatever documents that were generated, biometry sheet, consent process, everything was normal, correct for the left eye. But doctor, when he gave the block in the right eye, opposite eye. because it was noticed during the timeout in the operating room, it was prevented. It is called active failure. So where everything else is normal, your process, everything is normal, but the person who is delivering the care makes a mistake, we call it as an active failure, acute failure. It's very difficult to address it. And it's something really people have to pay attention to that. But what is common is it's usually lack of a safety culture, which is talks about the policy. It's about the lack of protocol and processes. It's about lack of having a proper technology to prevent these errors and lack of communication. So it's not the people, all these errors, what the people make prior, the people at the end of point where they deliver the care, they make the mistake. So it's not the people, but it's the whole system that makes a mistake. So let us look at another scenario. There was a lapse in a documentation where a patient was advised to right eye DCR. The admission counter staff entered it as a left eye, and all the subsequent documents were generated for the left eye, a transcription error which could have led to a wrong surgery for that particular patient. Similarly, at a point, just to improve the post-operative refractive error, we moved from applanation to immersion method, and suddenly we noticed a patient with a large refractive error. The reason being it was done using immersion method, but they used an applanation mode. So all these errors, majority of we think the majority of the errors result from individual recklessness or action of a particular group of people, but it is not so. It is because of the faulty system, faulty processes and conditions that led people to make these errors. Yeah. So I'll just share some of the principles of patient safety for eye care as we have learnt it over a period of time. The foremost important thing is how do you increase awareness about patient safety in your team? How do you create clarity to staff on different dimensions of quality and safety? And we had held workshops way back in 2010 and 11, just openly discussing how safe or unsafe is our hospital. We asked everybody to talk openly as to what goes wrong in each of their hospital, because to err is a human. We also did a root cause analysis. We introduced a JCA, patient safety goals as we understood at that point of time, which was really difficult for our staff to understand. But at the same time, we also brought in a culture of reporting. So we brought in a reporting page right in our intranet page, which is accessible to every staff of the hospital. They have to just click on that incident reporting page, and it comes out a page where it's very simple to enter all the details. The whole thing is anonymous. You don't have to disclose your name unless you want to do it. So once you do it, a mail is generated and sent to the chief medical officer, the quality in charge doctor, and also to the manager, and who take do the root cause analysis and do what is necessary. So this reporting also helps us to kind of really define what are the patient safety goals. We have put together about 10 goals, not including the correct eye surgery, correct IOL power, how do we minimize the mortality, how do we minimize the endophthalmitis, how do we avoid medical diagnostic errors, medication errors, spectacles, all of this we were able to cover in that. And the fourth thing you have to make, if you want to avoid this, you have to make your staff understand that safety is related to the work process. The reasons, or the causes for error in our hospital will be very different from another hospital. So once you understand that, you can create system. The problem in Aravind is that one person does one work, so which as a result we have multiple handovers. So errors relating to patient identification can happen. So we really stress on the identification protocol. If it's an OPD patient, it is a must that you use the ID card to identify the patient. It's an inpatient, you have to use the wristband to identify the patient. So this, so developing that culture is also very important. And we also brought in a standardized timeout safety checklist over a period of time. And again, training across the system is very, very important. For each of the areas, we created safety protocols. We have about 30 such protocols covering all the areas that is shared with across everybody who's involved in the particular area. And we also have created posters which were displayed in the work area so that it's easy for them to refer to. And again, we also said what a biometrist can report. A biometrist can report if a wrong eye has been advised by a doctor. if there is an interchange of the diagnosis, if the doctor has missed the silicone oil in the diagnosis, whether whether he has missed a multifocal IOL in the other eye, whether there was a wrong ID card. Similarly, any mistake made by the biometrics is picked up by a ward nurse or a OT nurse and is reported. And again, constant monitoring is very important. Without data, you cannot do it. I'm just sharing the data for 2019, wherein we had seen close to about 9 lakh outpatients and performed about 1.6 lakh surgical procedures and lasers, and there were about 490 incidents were reported. A lot of that you can see it's a missing documentation, wrong documentation, patient identification error. But we had 3 safety events. 3 of that was a wrong eye block and a 1 wrong lens design. So if you have something like this, you have to also go back to the board and understand why this is happening. For example, a wrong eye block, we were used to make a single mark. Just to avoid this wrong eye block, we also created 2 markings. Even that did not help, as you can see. So once then we made sure that this was being done by a doctor individually. So made sure that one more person will stand with the doctor to make sure that as a team they don't make a mistake. So for the last 18 months, I can say there was only 1 single error relating to this. And again, it's also important to use the technology. Since we have moved to EMR, we have mandated certain things, what you call as a rule engine. So unless you enter the ID number of the patient, the record will not open. So you have to get the ID card from the patient. Certain number is available only with the patient. And again, the doctor can advise right eye, but he can tick the left eye in the EMR. Just to make sure it doesn't happen here, a pop-up will come. A doctor has to say yes or no, only then you'll be able to move on. And again, there used to be IOL related issue errors in the sub-store. So we had brought in a system where the IOL has to be scanned. So a lot of things goes into the system. So scan, and if it matches with the EMR data, only then the nurse will be able to issue that. So bringing in some of those technologies is also very important. Again, more important is how do we involve everybody in the hospital. So today we have about close to 40 teams across the hospitals, and about 700 to 800 people are involved. They are all champions. Everybody is involved, but there are about 700, 800 champions we have created. Just to conclude, the safety errors in eye care is very common because it's a bilateral organ. There's a high volume specialty. We have multiple treatment options, multiple measurements. More than that, large number of our patients are very vulnerable. So ensuring safe eye care becomes really important. So it's important that we do that in each one of our practice. So each one of you need to identify where errors happen in your practice, understand how they happen, reduce the complexity and develop reliable process for each of that, create independent checks for key processes, and creating the culture of safety. It should not be just done as a work, but it has to come really out of involvement for the patient. So you need to create not just one role model, but role models and teams across a team, across a hospital. That is how we'll be able to take care of this problem. I really chose this particular topic. This is something very least talked about in our meetings. I feel that we need to really give importance in the scenario of rising medical legal cases across our country. Thanks a lot. Again, I thank the opportunity to share this work with all of you. Thank you.